mature intumescent cataract with a small pupil. After main incision, intracameral dilute mydriatic with local anesthetic agent was injected, and anterior capsule was stained with a trypsin blue dye. After that, OVD was washed and AC was maintained with HPMC OVD. Capsular bag was decompressed by aspirating a milky fluid by the 27 gauge needle. The purpose of this is to decrease the intralenticular pressure because of intumescency of a white mature intumescent cataract. The anterior chamber is formed with the viscoelastics. The continuous curvilinear capsulorhexis is being initiated with a bent needle cystotome. The main phaco incision was enlarged and the remaining capsulorhexis was completed with the help of Utata forceps. The side pod paracentesis is being made. The capsulorhexis is being enlarged by a cut with a venous scissor and then later enlarging that traxis with the help of Utata forceps. And the main hurdle in the capsulorhexis is the small size of the pupil, and now dialing the nucleus with the help of viscoelastic cannula tip. Now inserting the phaco probe carefully into the anterior chamber, and then after initial pre-cortex expiration making a trench. So my primary purpose was to do a nucleus management with the help of stop and chop technique, detecting the iris to increase the visibility from the pupillary area to make an adequate size and depth of the trench, and now attempting to divide the nucleus from the trench, and after rotating it, chopping the other half of the nucleus into two pieces, and then dialing another half towards the tip of the phaco probe, and then engaging the piece at the phaco probe and chopping that nucleus piece and trying to be in the safe position central and at the iris plane, bringing the wandering pieces of the nucleus towards the center and aspirating and emulsifying them at the pupillary plane, because this is the safest position of doing the phacoemulsification. And note the safe position of the chopper to keep the back posterior. Now injecting the viscoelastic and then aspirating the leftover cortical matter, because in this white cataract the PC is very fragile. Because the size of the pupil is very small, there may be a small rent at the periphery, so injecting the intracameral triamcinolone to ensure whether there is any vitreous prolapse or any posterior capsular rent, but fortunately there was no any such complication. So after washing it out, injecting the OVDs to inject intraocular lens. This is a 4 haptics intraocular lens, and instead of dialing it, I am just putting it inside the bag with the help of a gel cannula, because there may be any extension of the cavity capsule. If we try to dial it, it may rip off the anterior capsule and extend it posteriorly. And after inserting the intraocular lens into the bag, aspirating the leftover viscoelastics. After that, stromal hydration of the side port incision. I usually avoid main port hydration and injecting anti-cancer antibiotic. And this is the first post-operative day picture of the patient. Vision improved from 660 perioperative to 690.